My next speaker, man, I'm excited again. Dr. Roberto, I'll add the accent, Lorusso, is a full professor in the Department of Cardiothoracic Surgery, Heart, and Vascular Center at the Maastricht University Medical Center, Cardiovascular Research Institute in Maastricht, the Netherlands. He's that special gentleman who is always willing to take on any challenge asked of him. We just do not have enough time to mention all the professional societies that Dr. Lorusso is a member of or contributes to with his objective of advancing knowledge in the field of medicine, and thankfully ECMO as well. I have asked Dr. Lorusso to speak on the myriad or optimal ways that advanced ECMO clinicians are cannulating these days based on a myriad of pathologies. His talk is entitled, "When I Was a Kid, Hybrid Meant Monster," quote unquote. Is this also for hybrid ECLS, unquote? We are so proud to have Dr. Lorusso join us today. Roberto, thank you.
Thank you, Bill. Thank you, everybody. I'm really honored and really pleased, really delighted to be with you today. And I hope to give you just a very personal and humble perspective of what is, I think, going to be ECLS and ECMO in the upcoming future. So first of all, these are my disclosures. So just to start with, as I said, when I was a kid, of course, I liked very much, beautiful cars. But then all in a sudden, sometimes it happened that these nice cars had to be transformed. And this was a little bit an issue for me because when I was a kid, I liked the real cars. And when, of course, I was somehow also attracted by these kind of, transformations, and also about the kind of hybrid cars that you could see, particularly I would say in US. But I can tell you that also in Europe, this kind of fashion went on really in a quite remarkable way. So beside that, I mean, we know that ECMO was maybe like the red car in the upper panel, and now we are going to transform this ECMO in a very complicated and I would say something different from the very old times. So, but is transforming and making the ECLS hybrid scary? And I will try to discuss that with you in the coming minutes. So again, the problem is that we are facing in our current practice a sort of transformation. So it's quite a very challenging and of course appealing era in which ECMO, as it was supposed to be or it was thought in the past, is going to change completely. But is it really something good? Is it really something safe? Well, we posed this question to ourselves, sorry, a few years ago. You can see here we published this in 2017. And we think that indeed we have to start thinking differently. We have to start thinking out of the box, as it is really common to say today. And we have a lot of configuration. I don't want you to go all through this, but just these are a few, not all, the configuration that you can design with your ECMO ECLS system. And we tried also to really describe in details what hybrid ECMO is. And also, again, this was not really easy. And you can see again a lot of configuration, a lot of terms to define what is not anymore just two single cannulas, like a venous cannula to drain and arterial cannula to perfuse. It is not that anymore. But I want you also to understand that this is not a very recent, of course, transformation. This is a nice paper published by the group of Duisenberger, Matthew Bacchetta, and the co-investigator who look at the kind of effect of having an hybrid, so to say, a configuration. So like the veno-arterial venous or like veno-arterial, and they show that in a normal lung and in compromised lung, that the use of the hybrid configuration was much better in terms of oxygenation in the normal, but also during a compromised lung. And this was also confirmed looking at the abdominal aorta. You can see here the difference was striking about the O2 saturation once the hybrid mode was compared to the normal mode. But is there a limit? We know that what is hybrid ECMO? Nowadays, we know that you can introduce one or even two or maybe even more cannula. So is this really the challenge of today? Should we introduce more than 3-4 cannulas in this patient? So is there a limit? And this was the nice title of this publication appeared just a couple of years ago. So, but is hybrid ECMO, after all, just the add of or the adjunct of one or more cannula to enhance the ECMO management? And we'll go through this during the presentation. And I can tell you exactly, just showing these drawings. You can see in this patient, you have the cannula here in the jugular, and then you have a cannula here in the anterior thoracotomy. So this patient has a spatial configuration because this patient is waiting for a heart transplantation, and he can be mobilized, he can walk, he can go around while maintaining this configuration. So again, ECMO is not only about recovery of the organ, but also is the way the patient is bridged to something else. And you can see here, this is a cannula going into the left atrium and going out from the chest of the patient. So again, you can see different kind of configuration, different kind of, you can see femoral and thoracic. So completely different from the previous and the past and the, so to say, ancient view and ancient perspective of ECMO. Because after all, this is going to be also the passage from ECMO to a more durable, like a left ventricular assist device. So we have to bear in mind that we are treating the patient to let them recover, but once in a while, this is not possible, and we have to switch to something else. And then ECMO should be also changed, should be adapted to a new configuration. We also know that now more and more the left ventricular unloading during ECMO, particularly, of course, during veno-arterial ECMO, is an issue. And we know that there are a lot of modalities. And you can see here that we made a review article a few years ago that we have a bunch of possibilities to unload the left ventricle during veno-arterial ECMO. You can see we have transaortic like Impella, we have aortic like EIBP or other things. We have pulmonary artery, or we can introduce a catheter in the left apex, in the left ventricle, or we can go to the left atrium. But again, you can see here we have a bunch of additional methods that we can use. So again, ECMO is getting more complicated. It's more, you know, is more structured, what to say. And after all, as you know very well, now more and more we are associating ECMO with additional device like intra-aortic balloon pump, like Impella. So ECMO is not only alone, it's not a standalone system, but it's sometimes a combination of devices. And indeed, is this going to be to impact let's say the clinical outcome? This is a paper, you can see 2011. The 2011 was already in this group from Zurich, looking at the configuration mode and the impact on the outcome. And you can see again that they were changing the configuration during the ECMO course, and some type of configuration were associated with a much better outcome. And you can clearly see here that as long as the hybrid mode, so the ECMO was more complex, you can see the upper line, the survival probability was much higher. This was also recently investigated by the University of Michigan group. Again, the hybrid mode, again, all the type of cannulation, you can see a lot of ways, a lot of modes. But we have an additional concept, because hybrid means not only the use of a more complicated, more complex configuration. You can see this is a patient I did in Maastricht, a cardiac surgery operation, a very, very, I tell you, difficult patient, 150 kilos, a patient with biventricular failure. So what we use an hybrid dynamic ECMO, and I will explain you. And this was in case, as I said, of biventricular failure, so very difficult. So what did we do? We put a cannula in the pulmonary artery, in the right atrium, and in the femoral artery. But the first configuration, you can see we were draining from both sides. So this was a VVA. So we were draining from the right atrium, the pulmonary artery, just to get a very, very effective unloading of the heart, and then reperfusing the femoral artery. As soon as we saw that the left ventricle was improving, then we started going to a different configuration. So the pulmonary artery cannula received a reverse flow. So instead of draining, we were perfusing. So now we were in the VIV mode. And the patient gradually improved so much the left ventricle that we could remove the femoral artery cannula and remain only on the right ventricular support. You can see here without oxygenation. So with the with oxygenation, so with the veno-venous, but also with the right ventricular support. This, you can see, it's a sort of dynamic change with the cannula first draining and then perfusing. So this is what we call now dynamic. So we change the flow direction according to the needs. So this is what we consider the combination of hybrid and dynamic ECMO. And again, this is done in many other situations. This is a very important paper just to show that if you have a cannula in the artery and in the vein perfusing, you must be, of course, aware of the difference of flow going to the different district. And you have to use, of course, flow sensor. You have to use occluder devices, because otherwise you will have flow going preferentially to some place where you don't want to go. And this is just to show that they did this kind of configuration in some patients, and they saw nicely that if you do not control the flow, you can see here that the cannula going to the internal jugular vein received most of the perfused blood coming from the pump. But once they had adjusted that flow with the occluder device, of course, the flow was going more towards the femoral artery and not towards the internal jugular vein. So this is a really very important concept to be applied. Another thing which is going to be, I guess, in the future, more and more we are working with a septic shock. In this case, it's very important to say that they use a double pump to make this configuration in a cardiogenic shock for a septic shock functioning better. This is also another concept of making maybe more complicated the ECMO support, but again, this worked very well, and they did a few cases. You can see also they used to have an unloading of the left ventricle and the reperfusing the axillary artery, and then the cannula coming from this way, also an additional venting in the left atrium. And again, more and more, as I said, more complicated. Again, you can see in this patient, there was a septic shock again. They could not make with one pump, and they just use a two pumps configuration. You can see the patient had two ECMO pumps, and this we know it's working in very big chap, maybe of a very big body surface area. But in this case, the patient was a small patient, but she needed a very high flow, which was not guaranteed by one ECMO pump. Again, hybrid ECMO is going to be, as I said, very complicated, but I think going towards the hemodynamic needs of the patient. So two venous drainages, two femoral artery perfusion, and they could achieve easily 5-6 liters of flow. This is just to show that case reports about hybrid ECMO, hybrid configuration are coming out every day. But this is what I think is hybrid ECMO. Hybrid ECMO is certainly at the beginning just adding a new cannula from the famous original and old-fashioned two cannula configuration. So one in the vein draining and one in the artery perfusing. But sometimes you need for a very high flow, and this is not manageable by one pump. So you can even use more than one pump. It's not absolutely adding a perfusion cannula like in VIV, but sometimes also you need to drain more, as you know. And sometimes hybrid is adding another devices like impeller, like intra-aortic balloon pump. This is to enhance and to make the ECMO working better according to the new dynamic requirements. And as I said at the beginning, also you can adapt the ECMO towards what is bridge to. Sometimes it's bridge to more advanced therapy like transplantation, like that. As I said before, we also introduced the dynamic ECMO. This is sometimes used to counteract the famous North-South or Harlequin syndrome, but also to favor a better unloading, sometimes the cannula in the pulmonary artery, and also to promote this kind of dynamic support. So we can change the kind of support we are giving. And again, this is towards a patient-tailored, hemodynamic-tailored ECLS support. And finally, this, as I said, also the dynamic ECMO is to change a configuration for a more durable treatment. But just to finish, this is a very nice mosaic which appeared in Pompeii in Italy. It was made in the second century before Christ. Beware of the dog. So be careful, because more configuration can be also more complicated, so more complications. You have to consider what you are going to do. You have to know also the pathophysiology of the ECMO flow. So you should know that more flow goes to some part. You have to manage that. And of course, you have to have a nice and established program to do that. So I think there is, in conclusion, a paradigm shift from the old-fashioned ECMO to more structured, more maybe complicated. So from a 2 single lumen, we are going to more durable lumen cannulas, for instance, from just two cannulas to more again hybrid. So conventional ECMO program to a more hybrid ECMO. And again, from the simple physiology of ECMO, now we have really complicated pathophysiology that we have to know about all these things. And as I said, from static ECMO, so two cannulas that you start from the beginning and you end up with the same configuration, we have now a dynamic ECMO, which could be changed along the ECMO course. And again, from just a circulatory support or protective ventilation, we are going to be even more protective towards the heart with the LVV unloading. This will be certainly another challenge in the future. So from invasive technique to minimal invasive percutaneous cannulation, again, circulation and lung support, we go to ventricle oriented, and from a system oriented, we go to a patient hemodynamic oriented ECMO. So I hope that I try to explain to you all the changes that ECMO is really getting more and more in these days, but it will be for sure more complicated, but more comprehensive and more, let's say, patient-tailored, hemodynamically tailored device. Thank you for your attention.
Thank you, Dr. Lorusso. Very eye-awakening, I would say. A couple of those pictures with more tubing than patient. That was that's pretty cool. I guess a couple of questions that came up, and I'm sure our panelists will have more. When you do your simple fem-fem approach, and you're seeing a harlequin or a mixed cloud syndrome going on, if you can't remedy it by different methods of increasing pump flow or decreasing cardiac output, with pharmacological agents or whatever, some people will look to possibly go to an axillary or subclavian arterial return approach, possibly using an 8 mm graft or so you get more antegrade flow rather than retro flow through the femoral artery. Have you done that for that reason? And can you do that percutaneously at all?
Okay, so thank you for the question. Okay, so first of all, even the reply to this question, like Harlequin syndrome, the north-south, you just go and you can cannulate the axillary artery. Well, that's possible, but it depends the type of patient. Certainly, I would say for the time being, the cannulation of the axillary artery percutaneously, I would completely discourage that, because it's a very thin artery, very delicate artery. If you have any problem, then you will be really in big trouble opening a subclavicular, maybe a site, and repairing a bleeding artery in that, where you have the plexus brachialis, so you have a nerve going there, so you have a lot to lose there. So I would say that if I have such a problem, I would certainly try first with non-aggressive. I would, for instance, try to put more a cannula in the jugular vein. And if this doesn't work again, I would follow the suggestion of my good friends from Stockholm, trying to drain from the internal, the superior cavern vein, and trying to reverse this is exactly a dynamic ECMO. So you perfuse the right jugular internal vein, then you drain from that. And I would try something different for sure. So I think, again, what I want to underline is that in the past, and we have to acknowledge that this is the problem, in the past, we made ECMO too simple. And it is not. It is not. It is not only by the formulas or the calculation of oxygen content and so. It's much more than that. Pathophysiology is completely changed. And also the pathophysiology of the disease changes along the time. But in the past, we used to put two cannulas, and we tried to be so arrogant to say, okay, these two cannulas will do fine from the beginning to the end. Well, it's not so simple, as I said. We were lucky in many instances that this kind of configuration worked. But looking at the patient where we failed, that taught us that we were wrong, that we had to change a certain point of time, a certain moment we had to change to adapt to the new situation, like, for instance, Harlequin syndrome, but this is just a very minor issue. So I think that in the future, I always tell my younger collaborators, look at congenital cardiac surgery. Congenital cardiac surgery, you have always, holes, you have defects, you have circulation, which is different from the normal, and you have to make a reasoning. You have to think, you have to reflect what you are going to face in terms of pathophysiology. And the same thing is in ECMO patients.
Yeah, great answer to that. I wonder, and forgive me if I'm wrong, you have a bunch of great papers to show the intensity and the increase in usage of hybrid dynamic ECMO. Has ELSO provided an algorithm to help clinicians decide what other types of cannulation they might use based on a certain pathology?
Yeah, no, there are already recommendations, sure. But some of them, they have to be made still, or yet, let's say. I make you another example. If you have to treat a patient in cardiac arrest, I mean, the patient had his own injury, like acute myocardial infarction, the patient arrested. So you have the injury of the acute myocardial infarction, and then you have the injury made by the cardiac arrest, because you have, low flow or no flow. Then you put an ECLS in this patient. Do you think that this patient is the same as, I don't know, a post-cardiotomy or a myocarditis patient, acute myocarditis? It's totally different. We need to have adapted and patient-tailored, or I would say pathology-tailored configuration. So in my point of view, for instance, after a cardiac arrest, I think that the heart must be completely unloaded. So the left ventricular unloading, in my point of view, is much more needed after a cardiac arrest treatment, just to make you an example. So we made, again, things too simple. They are not so simple. And when we fail, we should think that maybe we didn't do the right thing. It's not because that patient was irreversibly damaged. This is my point.
I noticed that none of your patients on the pictures that you showed were bleeding. I wish you could teach me how to do that.
Well, that's another very, very important and appropriate point. As I said, with a mosaic of Pompeii of more than 2,000 years ago, is you have to be careful. You can go very close to a biting dog. So putting a new cannula in this patient, you can really create a disaster. And I know that a lot of my friends, and particularly someone from Karolinska, will say, look, guy, when you think to do more or to add a cannula, go and take a coffee and stay away from the patient. I agree. And in fact, a lot of times to my collaborators, I always say these words. Look, guys, don't touch, don't breathe, don't talk, don't do anything. And I know that most of the time it will be right, because we are more prone to provide complication than to provide advantages and benefits. It's true, but not all the time. So not all the time, this is the appropriate behavior. Stay away from the patient. No, you have to stay really on the patient, looking what's going on, and then you decide what is really needed. I agree that you have to put a drain. If you have to do anything in this patient, you can really go into deep. But I think that this is something that we have to be careful. So not overdoing, but reflecting, thinking, and do the right thing.
Thank you very much, Dr. Lorusso. That's a very interesting talk. And with all the comments and chatter that's been on the live chat, there's a lot of questions on here. One of the questions from they've been talking about with the different two pumps in one patient. Do you see the recirculation seen more often? This is a question from Sean Devereaux. And if so, how's it addressed and fixed in the two pump ECMO?
Well, this is another good question. And that recirculation was not happening because one cannula, the two ECMOs, one cannula was in the draining cannula was in the right atrium, and the other draining cannula was transeptally positioned in the left atrium. And the other two cannulas, arterial ones, were in the two femoral arteries. So actually, these kind of two pumps, two ECMOs, were completely unloading the heart from the right and the left side, and then all the flow was going to the two femoral arteries. What I would say, which was not completely clear in the paper, is in this situation, where you drain the right atrium and you drain the left atrium, what you end up is that you will have a completely empty left ventricle. And if you have a peripheral artery cannulation, you risk that your aortic valve will not open at all, because your high flow, retrograde flow will go towards the heart, and the heart, completely empty, will not be able to open the aortic valve. So again, as I said, it's not so simple. You have to continuously monitor what you are going to induce. And this is what I say is the pathophysiology, the ECMO pathophysiology. ECMO pathophysiology is not only about shunting, about recirculation. It's also what is your configuration going to
13 hours
to induce.
Thank you, Dr. Lorusso. We have a lot of questions about asking if the outcomes for the hybrid approach is more successful than the traditional.
Well, as you know, unfortunately, we have a lot of publication most of the time of positive results. So in many situations, I'm sorry to say that the bad results most of the time are not published. So I don't want to make, again, a sort of campaign towards or in favor of hybrid ECMO. But I must say that even if you look the very latest experience or ongoing experience of COVID-19 patients, I think that at the very end, if you look at the kind of configuration we use in this patient, which was completely, I must say, 91 or 93% veno-venous configuration, simple veno-venous. But then if you look at different configuration or the way this patient died, the more than 50% of the patient died, we have to think about and say, were we completely right in the configuration we use for these patients? Could we do a little bit more for this patient or differently from this patient? So I think that the outcome, I believe that if we can follow better the kind of change of hemodynamic or respiratory situation, so cardiac and respiratory, and even the circulation itself, like a septic shock or or distributive shock or whatever, I think that, again, we will know in the future that we have to be more careful about the interaction between heart and lungs. And for instance, maybe in the future, the veno-venous ECMO will not be like we are doing now, but we will do a different way. Like, for instance, with the double lumen cannula in the pulmonary artery. So we will do a VV ECMO, but at the same time, providing the cardiac support of the right ventricle. So I'm saying that we are discovering a lot of new things now. So things are getting, I believe, a little bit clearer, and we will be, I hope, better in the future to manage our patients.
I got a question. What percentage of your patients do you, as far as all your ECMO patients, what percentage do you consider that you put on as hybrid ECMO?
It's increasing. Up till 5 years ago, it was, I would say, almost not zero, but very few. Now we are going more and more to, I would say now we have at least 15% of the patients who are undergoing an hybrid ECMO. So, and it's steadily increasing. That is because now there is the conception. The concept is there now. In the past, it was not considered. Now we consider it, although we are still reluctant because we know that putting a new cannula, for instance, new cannula, but again, it is a little bit reductive talking about only adding a cannula. We have to talk about something more complete, which could be also with a device, which could be an intra-aortic balloon pump, which could be Impella, which could be whatever will come out in the market, I would say, for the treatment of these patients. You know, I just reviewed the paper, just to make an example. I cannot make you aware of more than that for confidentiality, but there is a big study comparing ECMO alone, ECMO plus intra-aortic balloon pump, and ECMO plus Impella. And it's clear that the ECMO alone had the worst results. So again, this means that most likely the LV unloading in ECMO will be important in the future, more than what we think now.
Have you seen an increase in leg ischemia by the double pumps? And if so, how do you check for leg ischemia?
No, first of all, the double pump, it was just a case. I also used two pumps in one case, in one patient. The leg ischemia, I think, is going to be less a problem. Less and less because I can tell you the 100% application of the leg, the distal leg perfusion, first of all, was a major breakthrough. As you know, you are well aware, in the recent past, we were still thinking, should we all the time perfuse the leg if we go on peripheral ECMO? I hope that this is not an issue anymore. We must perfuse the limb all the time. This is, I would say, really a must. Then how do you do that? Well, that's another story, because now new cannulas are coming out of the market. As you know, there is now a new cannula you can use just a cannula which perfuse retrogradally, but it perfuse also the limb contemporary. So this is also what technology is giving us. So I think that the limb ischemia rate is absolutely going down, either for the use of smaller cannula, either because we distally perfuse all the time, and also because we will have dedicated device in the future. So I am really confident that this will be less and less a problem.
Is your staffing remaining the same when you do a lot of these hybrid ECMOs? Or are you having to increase your staffing to take care of them?
No, not at all. No, but of course you have to make them aware. Sometimes if we say we use a very strange configuration, we make, of course, a big drawing to all the personnel just to show what is all about, what are the problems, what are the potential threats, potential problems and complications. Yes, you really have to pay attention to that.
I'm curious to know what your ideas are for newer programs in terms of balancing the benefits of hybrid ECMO against the risks of the complexity.
Yeah, no, that is absolutely a very critical question and critical issue. As I said, I think that a very, very big mistake would be to approach this kind of, let's say, strategy without an appropriate training and education. That is absolutely, even, I would say, even more important than just getting the right education and training for starting ECMO. Because here you are going to go into very difficult situation, either for, deciding what to do, first of all. So patient selection, mode selection, complication prevention, and patient management. I showed you that I know, and I have other colleagues confirming that in some centers, they put a cannula in the superior, in the right jugular vein for a VAV ECMO for an Harlequin syndrome, and the patient died because the majority of the flow went to the venous cannula upwards and almost no flow in the femoral artery with just 1 liter. And the patient died because of low cardiac output, of course. Not cardiac, actually, low ECMO output in the femoral artery. So this is just a very trivial, but unfortunately for that patient, very important misconception and misuse of a more hybrid configuration. But we know now that we have to be really careful. But it is really, I would say, important to acknowledge that, for instance, Harlequin syndrome, when was Harlequin syndrome conceived and considered important? Well, Harlequin syndrome was known quite long a time ago, but when was it considered something that you had to be treated? Not too long ago. That's another issue. Not now we know that we must take care of that because we can have problems.
Dr. Lorusso, there are some questions with VV ECMO about using dual lumen single venous cannula, namely in this country, the Avalon, the Crescent, or the ProTech. And what I've seen and what people are asking is people having very different experiences on maintaining excellent position or optimal position to reduce recirculation and to increase oxygenation to the right side of the heart. Are you having those issues as well? Or do you have any suggestions for those programs that often do experience a malpositioned VV dual lumen single cannula?
Well, that's another very good question. I know, and first of all, double lumen cannulation should be also approached with respect. It's not just as easy as putting the normal 2 cannulas in the venous side and in the jugular side, and that's it. It is quite more demanding. Could be, again, easy, straightforward, but you could have a lot of problems too. And the positioning certainly is critical, as we all know. I think that's a major advance for sure. I mean, if you consider about patient mobilization and the time, the kind of course, gain you can have with the double lumen is really a lot. But still, also 2 cannulas work perfectly. So I don't see that. How to say, a sort of final competition to choose who is the winner or not. But of course, the technology must help us to do something even better, or something which can be an addition or an adjunct to our portfolio when we are treating the patient. So the double lumen cannula in the pulmonary artery is definitely a major advance, because you can have a patient who is going to be or going to develop a right ventricular failure, and with the double lumen cannula in the pulmonary artery, you just solve that problem. I use that, and to be honest, I was really happy, because I had a patient after cardiac surgery, after aortic dissection, developing right ventricular failure, but also with lung failure, and we treated very nicely with this cannula. But also the double lumen cannula normal, of course, here you have to rely more on your right ventricular support. If you have problems, I think that the double lumen cannula in the pulmonary artery is the solution. So I think, again, technology is giving us different products. Again, in the past, for 25 years, we had only the same cannula, no change whatsoever, always the same cannula. Now we are looking at, fortunately and finally, we see that technology is providing us different products. And this should be also part of the concept of hybrid ECMO. You have to choose the right cannula for the right patient. It's not always the same cannula, just one venous and one arterial, and that's it, or 2 venous. No, you can decide, and you can adapt your configuration and patient selection according to the needs.
I want to add that I've seen this a couple of times for those programs that are vacillating between, let's say, the Avalon and the Crescent VV cannula. The Crescent does have a collar, so to speak. I'm not sure what the pieces.
Yeah, you can see better the position of the hole towards the tricuspid valve. That's true. So you can see much better the position of the cannula.
But I believe there's a collar too that needs to be put on before it's inserted for tying it down. And I believe, well, I've seen some programs forget that, since the Avalon does not require that, and that helps to maintain that position. So for those of you using the Crescent, be aware of that extra device.
But again, both cannulas have advantages and disadvantages. You know, the Crescent is a little bit longer. You can, you know, be maybe safer in the position, but at the same time, Avalon has additional advantage. So I think we have now, thanks God, I think very nice products, and maybe in the future even better. So I think now we have more weapons in our hands to treat this patient. And this is, I think, really fortunate. Really, I feel much safe today than, I don't know, 15 years ago when I was in front of a patient requiring ECMO. Now I can really choose a lot of things, a lot of configuration.
Yes. Can I ask you another question? We got 6 minutes to go or so, and then we have Mr. Riley coming up. And this is a little bit outside different cannulations, but it has to do with size of cannulas or drainage. When you have a respiratory patient that seemingly has a healthy right ventricle, left ventricle, and you're putting them on VV ECMO, do you have, and it has nothing to do with RV failure, do you have a targeted flow that you are attempting to guesstimate so that you can pick a size of cannula to fit into that patient anatomically? Obviously, if it's an RVAD, you want to go 100% flow of whatever systemic circulation is, but not so much with VV. Can you make a comment on that, on your opinion, please?
Yeah, well, again, in the past, I could say really, and I could answer in, I would say, 10 seconds. Now it's different. And I tell you a few examples. It depends what kind of lung injury and lung compromise you have. It depends how big is the chap. It depends how are the cannulas you are positioning because of the recirculation. It depends how flow you need to, provide to get a decent saturation. And all these aspects you have to take into consideration because you have the weapons now to adapt the kind of treatment you can make. And I make an example. If you have a big chap and you have to have a quite high flow, like, I don't know, 5 liters of flow, but then you get a high recirculation. So, I mean, you have 5 liters, but the circulation is more than 30%, you are going to get in trouble. Then what to do? Again, then you start, but maybe having the cannula in the pulmonary artery, you have no recirculation, so you could go to 4 liters. So you don't need a high flow to get what you get with 5 liters, but with a no. So you have to really go into details of the patient. You have a right ventricular which is already dysfunctional, and if you need a high flow in this patient to get a good saturation, I think it's again, pathophysiological mistake to go with a normal VV ECMO, because this patient with 5-6 liters of flow in the right ventricle, dysfunctional right ventricle, this patient will go into troubles. So you have to anticipate, you have to avoid this problem, and maybe going to directing the pulmonary artery, you have less recirculation, less flow, and you will bypass the right ventricle, so not having that problem. So it's not a straightforward reply and response. As I said, in the past, we didn't have so many opportunities. So it was quite simple. I say, okay, as long as I can go with high flow, with VV, okay. If it doesn't work, I go into VA. That was the transition. Nothing else, nothing more. Now we can have a different thing, and I think we have to use it. At least we have to start thinking that we can make different things.
Well, thank you very much. I mean, we'll look for more tools coming from ELSO or other papers to help us to learn the many different hybrid models that you had shown in many of your pictures, because there's a lot of learning to do. And not only us clinicians as perfusionists or ECMO specialists, but we've got to get that through the physicians that we are supporting as well. Sometimes that communication isn't always equal there, unless you're an ELSO type ECMO physician keeping up with the data. So we look for those tools coming in the future that we can provide information to our physicians that are in charge of patient care as well. Thank you very much.
No, it was really a pleasure. Nice discussion. Thank you very much for the opportunity.
Thank you.